Evaluating vital signs is a fundamental step in any patient encounter. However, interpreting vital signs in geriatric patients can be challenging due to age-related physiological changes, comorbidities, and medication use. Misinterpretation can occur if vital signs are not considered within the context of the geriatric patient's unique physiology and medical history, potentially leading to delayed or inappropriate treatment. Temperature and infection. Older adults may present as normothermic or even hypothermic despite having a severe infection. This is because the body's ability to regulate temperature can decline with age, and inflammatory responses may be blunted. Therefore, a normal temperature does not rule out infection in geriatric patients. Pearl. Always consider infection, even with a normal or low temperature, and look for other signs like changes in mental status, functional decline, or subtle increases in respiratory rate. Pitfall. Relying solely on temperature to rule out infection can lead to misdiagnoses and increased morbidity. Heart rate and tachycardia. Tachycardia, which is often expected in serious conditions like sepsis or hypovolemia, may be absent in older adults. This can be due to intrinsic conduction system abnormalities, for example, sick sinus syndrome, atrial fibrillation, or the use of medications such as beta blockers, calcium channel blockers, or digoxin. These factors can mask the expected heart rate response to physiological stress. Research has shown that even mild tachycardia, with a heart rate between 90 and 100 beats per minute, can indicate increased mortality risk in geriatric trauma patients. Pearl. A normal heart rate in a geriatric patient may be relatively elevated for their baseline. Obtain a thorough medication history and consider the possibility of masked tachycardia. Pitfall. Assuming a normal heart rate indicates stability can be misleading. Evaluate the patient's overall clinical picture and consider their baseline heart rate. Blood pressure and hypoperfusion. Chronic hypertension is common in older adults, with a prevalence of up to 80% in those over 70 years old. Consequently, their bodies may be accustomed to higher blood pressure levels. A normal blood pressure reading in a geriatric patient with chronic hypertension may actually indicate significant hypoperfusion. Studies have shown that occult hypoperfusion can occur with systolic blood pressures between 130 and 150 millimeters of mercury. This can lead to end organ damage if not recognized and addressed promptly. Pearl. Know your patient's baseline blood pressure. A drop of even 20 to 30 millimeters of mercury from their usual systolic BP can be significant. Pitfall. Treating to a normal blood pressure without considering the patient's baseline and end organ perfusion can result in iatrogenic harm. Defining hypotension in trauma. Defining hypotension in geriatric trauma patients requires age-specific considerations. A study of nearly 25,000 trauma patients found that the optimal definition of hypotension varies by age. For patients aged 50 to 69, hypotension is defined as a systolic blood pressure of 120 millimeters of mercury. For patients 70 years and older, it is defined as 140 millimeters of mercury. Pearl. Use age-adjusted thresholds for hypotension in trauma to guide resuscitation efforts appropriately. Pitfall. Applying a universal definition of hypotension can lead to under-resuscitation in older adults, resulting in poorer outcomes. Pain perception and peptic ulcer disease. Altered pain perception is common in the geriatric population due to age-related changes in the nervous system and cognitive impairment. This can lead to atypical presentations of common conditions. For example, endoscopically proven peptic ulcer disease is painless in only 8% of younger patients. However, in patients over 60, it may be painless in up to 35% of cases. Pearl. Always maintain a high index of suspicion for serious illness, even in the absence of typical pain. Pitfall. Dismissing the possibility of a painful condition based on the patient's lack of pain can result in delayed diagnosis and treatment. Management of hypertension. Isolated hypertensive readings without end organ dysfunction, for example, stroke, myocardial infarction, acute kidney injury, do not require aggressive treatment in the emergency setting. Rapidly lowering blood pressure in these situations can lead to hypoperfusion and adverse outcomes. Aggressive short-term treatment of systolic blood pressures of at least 180 millimeters of mercury and diastolic blood pressures of at least 110 millimeters of mercury does not improve outcomes in the absence of end organ dysfunction. Patients with sustained elevated blood pressures should be referred to primary care for longitudinal treatment and management. Pearl. Focus on preventing end organ damage rather than solely targeting specific blood pressure numbers in acute hypertension without evidence of acute injury. Pitfall. Overly aggressive blood pressure management can be harmful. Gradual reduction and outpatient management are usually more appropriate for isolated hypertension. Conclusion. Interpreting vital signs in geriatric patients requires a nuanced understanding of their physiology, medical history, and medication use. Providers should be aware of the unique presentations of common conditions in this population to avoid misinterpretation and ensure appropriate and tailored care. Recognizing these differences can lead to more accurate diagnoses, timely interventions, and improved outcomes for geriatric patients.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.